Hello, my name is Divya Shankar, and I am a clinical and research fellow at the Boston University Pulmonary Center. On behalf of my co-authors and myself, today I will present our study entitled Practice Changes Among Patients Without COVID-19 Receiving Mechanical Ventilation During the COVID-19 Pandemic. By way of background, the COVID-19 pandemic led to rapid changes in care delivery for critically ill patients due to factors including high ICU strain, shifting staff roles, and changed care locations. These changes may have not only impacted patients with COVID-19, but also those without. Thus, our objective in this study was to assess changes in common ICU practices for mechanically ventilated patients with non-COVID acute respiratory failure before and after the start of the COVID-19 pandemic. In order to do this, we designed a retrospective cohort study using the Premier Healthcare database from 2016 to 2020. The Premier Healthcare database contains enhanced claims data from approximately 25% of U.S. hospitalizations annually. Our cohort included adult patients over the age of 18 admitted to an ICU or step-down unit and receiving mechanical ventilation for acute respiratory failure. Only patients admitted to hospitals contributing data for all 5 years of the study were included. Patients with an ICD-10 code, which has previously been validated for use by my co-authors, were excluded from the study. The primary outcomes were monthly rates of common ICU imaging studies and procedures for mechanically ventilated patients with acute respiratory failure. The imaging studies we looked at were chest x-rays, chest CT scans, and lower extremity non-invasive vascular testing. The bedside procedures we looked at were bronchoscopy, arterial catheters, and central venous catheters. For our statistical analysis, we performed an interrupted time series study in order to assess the trend in each imaging study and procedure pre-pandemic, the level change at the onset of the U.S. pandemic, which we defined as April 2020, with March 2020 excluded as a pandemic transition period, and the monthly rate intra-pandemic until the end of 2020. Looking at Table 1, we identified 742,096 mechanically ventilated patients with non-COVID acute respiratory failure at 545 unique hospitals across the U.S. Patient characteristics across all years of admission are shown in this table. The key finding is that the patient and hospital characteristics remained stable during the study time period, with the exception of the combined comorbidity score. This is a summative score based on 20 comorbid conditions identified by ICD-10 codes, adapted from the Charlson and Elixhauser scores. The score range is 0 to 20. Figure 1 illustrates the interrupted time series finding for each imaging study and procedure we assessed. On the x-axis, you can see the month studied, and on the y-axis, you can see the percent of patients receiving each imaging or practice during those months. Our results show that prior to the pandemic, monthly rates of chest x-ray were decreasing, monthly rates of chest CTs were increasing, and rates of lower extremity non-invasive vascular testing were not changing significantly. At the start of the pandemic, both chest x-rays and lower extremity non-invasive vascular testing had a decrease in rate, while chest CT scans had an increase in rate. Intra-pandemic, lower extremity non-invasive vascular testing continued to increase monthly, while chest x-rays and chest CTs did not see significant change. Regarding procedures, prior to the pandemic, bronchoscopy and arterial catheter monthly rates were decreasing, while central venous catheters saw no significant changes. At the start of the pandemic, there was a decrease in rate of bronchoscopy, which then increased again intra-pandemic. There was no change in arterial or central venous catheter monthly rates at or intra-pandemic. This study has limitations. As with most studies using administrative data, there is a chance of misclassification of patients included and of practices measured as outcomes. In order to address this, we relied on charge codes which are directly tied to reimbursement, or we used validated ICD-10 codes. Thus, it is unlikely that there is differential misclassification over time. In terms of implications, our study findings suggest that imaging practices and bedside procedures changed in varying directions before, at the startup, and during the COVID-19 pandemic. It can be hypothesized that the increase in chest CT at the start of the pandemic potentially reflects clinician desire to assess for COVID-19 among other causes of respiratory failure, especially early in the pandemic when COVID-19 testing was less available. The concurrent decrease in chest X-ray and lower extremity non-invasive vascular testing at the start of the pandemic possibly occurred to minimize patient exposures in case patients later became COVID positive, as these procedures are commonly performed in a patient's ICU room. In terms of bedside procedures, the decrease in bronchoscopy also may have been due to concerns over transmission of infection via an aerosolized procedure, with a rebound in practice seen once providers realized that transmission was low with the proper personal protective equipment. The lack of significant change at or intrapandemic for arterial and central venous catheters may be due to the fact that many hospitals adopted specialized procedure services, typically consisting of surgeons, anesthesiologists, and interventional radiologists who were otherwise impacted by cancellations in elective procedures, and utilize these providers to place arterial and central catheters to address the increased needs of overburdened intensivists. Future studies based on this data should assess whether patient-centered outcomes might be impacted by the practice changes noted and study how to mitigate abrupt changes in ICU practice for further situations of high ICU demand. Thank you very much.